Now, this category of drugs are the neuromuscular junction blockers, and these have clinical utility and are an important drug class. And so we had already talked about the neuromuscular junction in a previous case, and understand that we're looking at the effects of acetylcholine binding to this neuromuscular junction receptor that involves the coordinated movement of skeletal muscle. Okay, and so here's that cartoon looking at the neuromuscular junction, and here you can see acetylcholine being released over the motor end plate. And over this motor end plate is where you have these nicotinic sub-M receptors, and here you see muscle contraction, sustained muscle contraction, when the appropriate concentration of acetylcholine produces enough binding to these receptors. Okay, and so these can further kind of be subcategorized, and this is kind of where there's a nice physiology, pharmacology tie-in. These can be further categorized whether or not they are depolarizing versus non-depolarizing, and so that again refers to the state in which the channel, whatever state the channel has the activity, and so understand that this sodium channel, which is essentially based on acetylcholine binding to it, is really able to exist in three different states. Okay, so there's a closed state, an open state, and then an inactive state. And a lot of people always forget about this inactive state. And I'm sure Dr. Shannon's going to talk in much more detail about the movement of ions, as well as the charges that occur as these different states of this receptor occur. So for the first part, let's focus on the depolarizing neuromuscular junction blockers, and we'll talk about their pharmacology initially. And so what are the depolarizing neuromuscular junction blockers? Acetylcholine, yes, acetylcholine, it's not a typo, succinylcholine, decamethonium, and then acetylcholinesterase inhibitors at high doses or at sustained doses have the ability to be depolarizing neuromuscular junction blocking drugs. Okay, and this is contrary to what we just learned in the previous case, where they were also labeled indirect acting agonists. That was referring to their effects on the acetylcholine receptors. Now we're talking about their effects on the neuromuscular junction receptors, which are a different group of receptors, both of which can bind to acetylcholine. Okay, so I do understand it's confusing. These depolarizing nicotinic antagonists, mechanistically, they have a real quick onset of activity, and their duration of action can be in the realm of minutes. And so what happens is that they bind to the receptor, and just like in the previous module, they act as agonists initially. So acetylcholine or acetylcholinesterase inhibitors, decamethonium, they act as an agonist initially. And so we know this because we see affinity with efficacy, okay, initially. But over time, we see reduced efficacy. And so whenever you see reduced efficacy, that is indicative of antagonism. And so these drugs have a kind of a unique outcome here. They have a two-phase mechanism of action. And so the first phase is basically agonism, okay? That results in the prevention of repolarization, okay? So if you prevent repolarization, you're promoting depolarization, same thing, and you see muscle twitching. And then the second phase, which happens a little bit later, is what's deemed the desensitization phase. And so even if there's acetylcholine present, there's no effect. Okay, so this is the antagonist phase. And so I alluded to this in one of the case discussions during one of the review sessions a couple of weeks ago, where you see agonist-like activity initially, and then antagonist-like activity later on. And so this is kind of a unique attribute to these drugs, and so that's why we spent a little bit more time on them. So what do you see? So at first, you see a little bit of paralysis, starting maybe from the fingers, maybe moving up the limb, encompassing the neck, then moving down the trunk. and then of course hitting the diaphragm, and then the recovery of the paralysis occurs in the reverse sequence. And so it starts at kind of the trunk and then kind of goes outward, and then the last thing to recover is the fingertips. And so where do we ever see these drugs used? Anesthesia. Okay, and so obviously this isn't an anesthesia case, but because of the biology that we're talking about, at least these drugs in terms of an introduction kind of fit. Okay, so in terms of the neuromuscular junction blocking drugs that are depolarizing, we're looking at pretty much all acetylcholinesterase inhibitors, high doses of acetylcholine, as well as the more resistant to acetylcholinesterases, succinylcholines. This is kind of a more stable version of acetylcholine. It's just basically an acetylcholine molecule with a little bit of a decoration around it to make it a little bit more steric hindrance. Okay, and so in terms of these neuromuscular junction blockers, we can see them being used quite readily, specifically succinylcholine, during intubation for like an endotracheal intubation. We can see them being part of electroconvulsive therapy. We'll talk about that at some point, probably in brain behavior. We can see them used for short-term duration for realigning fractures, as well as we can see them being used for muscle relaxants. Okay. And so in terms of the toxicity, these drugs aren't used for very long. There's really minimal side effects. The side effects are kind of similar to the non-depolarizing agents, which we'll talk about. And so the major side effect is this complication of breathing. And so if these drugs are on board for a long period of time, you see muscle paralysis. But in terms of intubation, that's what it's for. Okay, and so just the muscle paralysis could be severe. If the drug is given accidentally, the patient is going to need assisted breathing for at least some time. When you do inject these drugs, you can get hypotension. Typically, it's the result of histamine, and that usually is observed when you have bolus injections. Those bolus injections can be problematic. They can affect patients with glaucoma. They can produce hyperkalemia, and so if patients have underlying cardiomyopathies, you might want to consider looking at them more closely for arrhythmia generation. And then in terms of pharmacogenomics, you can see kind of prolonged blockade for some of these drugs. And so in terms of anesthesia, sometimes anesthesiologists have a hard time waking patients up. It's due to some genetic variation within these neuromuscular junction receptors. And so, if you've ever had somebody, a friend or family member in surgery, and the recovery period takes a little bit longer than what the anesthesiologist was suggesting, it's probably due to the fact that there's some genetic variation. So usually it's not dangerous. It just means that instead of maybe a 2-hour anesthesia effect, it might have a 6-hour effect. And so the patients take a longer time to wake up. They take a longer time to go off of the breathing apparatus, but usually it's not problematic. It's more just, more patient kind of monitoring. And so, you can get different types of durations of activity based on some pharmacogenomics. All right. And so this is the end of the depolarizing neuromuscular junction antagonist. Now we're going to kind of switch gears and go to the non-depolarizing drugs. Okay.